Thank you very much, Brian, for that introduction, and thank you very much to the organizers for inviting me today. I've visited Hopkins several times in the past, but this is the first time I've been invited to speak, so it's quite a pleasure for me. Today I'm going to talk about an initiative that WHO has begun called the E2020, which is working to bring countries to elimination to meet some of our 2020 targets. In 2015, WHO began a new technical strategy to cover the period through 2030. And we call this sort of our Greek temple of the global technical strategy. There are three main pillars. The first one involves ensuring universal access to prevention, diagnosis, and treatment. The third pillar talks about transforming malaria surveillance into a core intervention. And then my favorite pillar talks about accelerating efforts towards elimination and attainment of malaria-free status. And these three pillars make up the bulk of this technical strategy, which is linked to very clear but achievable milestones and targets, two of which are related to reducing morbidity and mortality, and the other two are elimination focused. So our targets are to eliminate malaria from at least 10 countries by 2020, another 10 by 2025, and then 15 more by 2030. And at the same time, ensure that no country that has become malaria-free reverts to having transmission reestablished. So in 2017, we started this E2020 initiative to identify countries that had the potential to meet those goals and then to help them with that effort. So we selected countries based first on a very light touch analysis of trends that suggested that they might be able to get to zero by 2020 based on their past history. Probably most importantly, that these were countries that had already decided for themselves that they were going for elimination. And then we consulted our WHO staff in the field to make sure that these countries made sense and that they were likely to have the political will necessary to get to elimination. And these are our 21 countries from 5 WHO regions. So we have 7 countries in the Americas, 6 in Africa, 2 in the Eastern Mediterranean, 3 in Southeast Asia, and 3 in the Western Pacific. These countries are quite distinct in terms of their malaria history, their malaria ecologies, their GDP per capita, their geographic location. But we find actually that they have many common issues, and that's allowed us to take advantage of this wide network. So the objectives of the initiative are to bring countries together. As I mentioned, even though they're so different, they share many similar opportunities and challenges. And to facilitate the sharing of those experiences and ideas and best practices. And it's quite surprising to me that, and maybe it shouldn't be, but you can find countries actually sharing ideas and countries from another part of the world taking them up. And a good example of this is a lot of the Latin American countries have been somewhat hesitant to use rapid diagnostic tests for many reasons, some of which is that they have very well-developed microscopy networks, and they wanted to continue taking advantage of that. But after one of our meetings and seeing how many of the African countries and Southeast Asian countries were using RDTs to good effect in remote areas, we now see several pilots in countries in Latin America, including Mexico and Costa Rica, that have decided to start using RDT. So this is an example of the power of sharing lessons and experiences. We also do monitoring progress and celebrating successes. And this also seems a little too easy, but it's surprising what kind of friendly competition that you can create through these meetings, where countries actually end up vying to try and be the first to reach zero or the first to reach a milestone. And that certification that Brian talked about becomes a very important motivator. Last year, the tweet from our director, Pedro Alonso, that got the most retweets was his tweet on the certification of Uzbekistan. I'm sure many people couldn't even find, I know I can't find Uzbekistan on a map, but that was an example of how important those successes have become to keep the good news about malaria going. And countries are very excited. Countries get very excited to see that they have an opportunity to finish this disease and to be internationally recognized for doing so. So the other thing we do as part of this initiative is to try and shorten the time between when countries become eligible for certification, that is after they've reached 3 years of zero indigenous cases, and the time they actually get certified, by preparing them in advance. As Brian mentioned, there's a lot of documentation that's needed. They need to make sure that they can actually prove that they've reached zero, and so this takes time. We're trying to start that earlier in the process so that as soon as they reach their 3 years, they're ready to go for certification, and Brian's panel can help to ensure that they have reached those criteria. So we're talking today about Africa, so I wanted to show the countries, the 6 countries that are in Africa that are part of the E2020 initiative. Starting from north to south, we have Algeria, which has been at 0 cases since 2015 and is currently undergoing the certification process, and we hope that will be completed by the end of the year. That would be the first country in the Afro region to be certified since Mauritius in the 60s, so it's quite an achievement. Just farther south, we have Cabo Verde, an island nation that, despite seeming somewhat off track for eliminating by 2020, as a result of quite a big, for them, malaria outbreak in 2017, actually interrupted transmission and has been malaria-free since January of 2018. So we think they're actually on track for elimination. And then in southern Africa, we have maybe a bit more of a challenge. The Comoros Islands has seen dramatic declines in malaria transmission in the last few years, but still continues to face challenges from resource limitations. The 3 southern African countries, Botswana, Eswatini, formerly Swaziland, and South Africa, that are part of the E8 initiative, are making humongous strides, have really reduced their malaria burden considerably, but still face a lot of issues from both internal, technical, operational issues to large-scale population mobility in the region. So are we on track? We've got now less than a year and a half till the end of 2020 to meet our 10-country milestone. And I'd say, yeah, I think we're in good shape. Currently, we have 7 countries out of 11 that have reached 0. Algeria, Cabo Verde, if we are talking about at least a 12-month period. China, which reached 0 cases in 2017. El Salvador, which also reached 0 in 2017. And then Iran, Malaysia, and Timor-Leste, which just reported recently that they all reached 0 indigenous cases in 2018. So we're left with Belize, Bhutan, Costa Rica, and Suriname, all of which reported fewer than 100 indigenous cases last year, and so still are on track to reaching 0. None of this is guaranteed. We continue to do everything we can to support the national malaria control programs to prevent reestablishment, but we all know that anything could happen between now and the end of 2020. So those are our GTS goals, and they seem quite ambitious. The idea of getting 10 countries by 2020 is enough work. Then thinking about the next 10 for 25 and 15 beyond that is really daunting. But it's important to note that even if we make those 35 countries by 2030, we will still be left with 55 malaria endemic countries. So even though the GTS seems to be very ambitious and we're off track in some ways, even achieving that is still going to leave us with a lot of malaria. The number of cases are projected, even after a 90% reduction, to leave us with 32 million cases in 2030 after accounting for population growth. So the GTS is an important, critical step on our road to a world free of malaria, but we still have a huge amount of work to do after that. And that brings me to the stagnation or the lack of progress that Dr. Moss mentioned. We have seen a decline in progress, a stagnation over the last few years. This graph shows the 10 highest burden countries in Africa, and you can see remarkable progress from around 2004 to 2015, and then at least a leveling off since that time. And this points us to an important problem, which is how do we eliminate malaria in Africa? There are 2 approaches. We've sort of started with this eating away at the edges, the so-called shrinking of the malaria map. You start from the easy places and work your way in. And there's a certain logic to that. There's certainly a momentum that can be created by starting with the low-hanging fruit and showing some progress. But I think this model over on the left is the one that is the true elimination approach. We have to start from the hardest places first. And those hardest places are the places with the highest levels of transmission in Africa, the most rural areas, the poorest areas in Africa. So really, even though our E2020 initiative is important in providing us with good information and some early successes, we all know that the true elimination effort is in the highest burden areas of Africa. And so that brings us to another WHO and Rollback Malaria Partnership initiative that is being led by the countries themselves, called the High Burden, High Impacts, a Targeted Malaria Response, which is aiming to reaffirm commitment and refocus activities initially in the highest burden countries, but eventually in all malaria endemic countries to accelerate progress towards the GTS. And there are 4 main elements. The first, of course, is political will. There's nothing that can be done if countries aren't on board, not only on board, if they're not leading and allocating funds and resources and personnel to being able to take on malaria. Secondly, using information better to be more efficient and more targeted in our programming. This is a very welcome shift in approaches and is being used, I think, to great effect already. WHO, we need to provide better guidance. We have tons of guidance gaps. We need to do a better job of working with the research community to communicate public health needs and the kind of information that are needed for policy development, and listen to countries to figure out what they need from us as well. And then finally, the response in countries has to be coordinated. We can't continue to work in silos with donors and partners separated. We need to work together in a coordinated fashion. And so the guiding principles relating at the moment to these 11 countries, 10 of which are in Africa and one of which is India, is, as always, this has to be a country-led and country-owned process. We need better coordinated support throughout the different partners with increased transparency to ensure efficient responses. We have to share data. Data can no longer just be for some kind of internal use or to prepare publications. These data are needed in order to inform strategic choices in mix of interventions in an area to achieve the maximum impact. And then the GTS targets are not being met not only in morbidity and mortality, but we're well off on the funding requirements that GTS needs in order to achieve its goals. So we need to do better international donor mobilization as well as mobilization of domestic resources. So I don't want to suggest, however, that that the elimination E2020 initiatives aren't important. They are. For one thing, we are responding to what the countries want. The countries want to eliminate, we will certainly be there to help them. But secondly, they help us by, in essence, giving us a glimpse into the future. By looking at what issues eliminating countries are dealing with, we can begin to identify the issues that most countries in Africa will one day deal with, and we can begin to start putting plans and strategies in process now. So I'm just going to share 3 lessons that have been learned from working with eliminating countries over the last few years. So elimination lesson number 1. Malaria will become largely a disease of adult males in the future. We know that already from Southeast Asia, where it's been known for a long time that most of malaria is occurring in adult males, most of whom are working in forested regions, either in swidden agriculture, forestry, or other kinds of activities in the forest. And so it's not so surprising to see Malaysia, an eliminating country with more than 4-to-1 males to females in the adult age range being infected in 2018. But this is a pattern we see repeated across all eliminating countries. So here's Costa Rica. Again, a 2-to-1 ratio between males to females in the adult age categories. And Cabo Verde, which is, its vector is Anopheles arabiensis. So this is an African vector. And these data suggest that perhaps countries get to elimination by doing a very good job controlling their indoor biting. And what's left, what's residual afterwards, is outdoor biting. However, it does have particular implications. The fact that most of the malaria in the future is going to be in adult males. This is not a population that malariologists have really any experience dealing with. We deal a lot with young children and pregnant women. We haven't had to work with this population that are known to be problematic from a public health standpoint. They're not around in the houses when you go to do household surveys. They're not around when you go to do MDA. And they have other factors such as poor treatment-seeking behaviors. So we're going to need to start learning from our colleagues who are dealing with adult male populations in diseases such as HIV, AIDS, and tuberculosis as to how are we going to engage them in the future in malaria control and prevention. And we have to better understand the risk factors in this group. Do they utilize LLINs at the same rate as adult women do? Are they using them less because they're traveling more and not taking nets with them? Do they have poor treatment-seeking behavior? What are they doing after dusk that puts them at risk of transmission? Are these illicit or illegal activities? And do they have occupational exposures that put them at risk? We need to start working with this group now in order to be ready for them at the end stage in Africa. Elimination lesson number 2. The last cases of malaria in a country will occur along an international boundary. So I'm going to give you a couple of examples. This is Iran, where you can see almost all of its cases occurring along its border with Pakistan. This is Ecuador, where most of its last cases are occurring along the border with Peru and a little bit with Colombia. In South Africa, their cases are occurring along borders with Zimbabwe and with Mozambique. In Nepal, all of their cases occurring along their border with India. In Mexico, more than 80% of their cases occurring along the border with Guatemala. And in Belize, most of their last cases occurring along their border with Mexico. This example of a time series of maps from China shows this whole idea quite beautifully. This is a map of China showing all the cases. I don't remember what year it starts exactly, but you can see that there are a lot of cases in the interior of the country, and as time goes on, those start disappearing, and the only cases that are left are in Tibet and along the border in Yunnan province that borders Myanmar. So we know that this is a common phenomenon. Every country that's not an island nation that has a neighbor that has a higher level of malaria transmission reports border malaria issues. But it's important to say that this is not necessarily an importation issue, but it's often confused with importation. So there are several potential causes of border malaria, and the most likely in many areas is that there is a cross-border transmission focus. This picture on the right shows a village in China and Myanmar where the border passes right through the center of town. It's an invisible border, invisible to the population, invisible to the mosquitoes. And so this is essentially one transmission focus. The ecology is similar on both sides. The population is the same on both sides. There's such frequent cross-border movement that most people don't even know they've crossed a border. And their mosquito population is clearly shared. So this needs to be treated as one transmission focus. There's no way that efforts on one side are going to have any impact on the transmission in the entire focus. We also know that there's usually a gradient of elimination efforts up to the border that ends, and that frequently the other side, the higher burden country, may not see their border as a problem because it's usually their lowest area, so they don't put their resources there. Borders can also be conflict areas between Saudi Arabia and Yemen. We know that's one of the reasons why they have continued transmission, because of the conflict that's occurring that doesn't allow for public health efforts in those areas. And then borders are often frequently remote and underserved. They need access to healthcare services in some of these places. So we need to begin understanding and better addressing these issues of border malaria. And we also have to move away from the idea that this is just about importation. It's definitely more complicated than that. We need to think of cross-border transmission foci as one site and work in coordination with the other country in order to address the issues there. Now, there are ways potentially through global fund grants to allocate and tag specific resources to the high burden country so that it will address their lower burden areas along borders with eliminating countries. And I just wanted to briefly talk about a really nice example from Argentina, which is also going through certification right now. Their problem has been in the north here along their border with Bolivia. And so beginning in 2000, they, in coordination with the Bolivian government, began doing house-to-house spraying, indoor residual spraying on the Bolivian side, thousands and thousands of houses every year, and doing house-to-house active fever searches. And so this graph here shows that the slide positivity rate in red started off at around 7% in 2000 and declined over time to about 0.2% in 2011. And at the same time, the number of cases coming across the border that were imported in gray began declining, as well as the indigenous cases in Argentina began declining. And Argentina was free from malaria from around 2011. So this was an excellent, coordinated, deliberate attempt. It wasn't just for malaria. They also worked on Chagas disease and cholera, but that had a very significant impact because they were treating the focus in that area holistically. So finally, last lesson, low-density afebrile infections are not yet critical to the end game. And why do I say that? Well, this graph here shows countries that succeeded in eliminating. There are 15 countries in this graph, and the dark line shows the median number of cases that these countries reported in the years leading up to elimination. So elimination occurred in year 0 here. And you can see that this is what we talk about when we say there's a long tail for elimination. 13 years before eliminating, countries were still only having around 1,500 cases a year. That's a very low number. So the population level immunity by the time they got to these last few years was really low. We can see this as an example in Cabo Verde. For the last 20 years, Cabo Verde has never had more than 20 cases per year until they had this outbreak in 2017, where they had this huge peak of cases. And during that time, they did reactive case detection with rapid diagnostic tests in over 2,300 people that were around an index case. They tested everybody. It was not a fever survey. And out of those 2,300, they found only 7 positives, true positives, 6 of whom were already symptomatic, and the 7th one became symptomatic on the day that they found them. So most of those 6 were likely to have gone for treatment immediately. Similarly, in Sri Lanka, 7 years before certification, so basically 4 years before they had reached elimination, they did a survey in the areas that had been most endemic in the country. They tested more than 3,000 samples by microscopy and PCR and found 0 positives. So what are the implications of not finding an afebrile parasite reservoir at this later stage? Well, first of all, when transmission is already very low and has been for a while, reactive case detection is unlikely to accelerate malaria elimination, unless there has been a rapid decrease in malaria transmission. So for example, here is Ngazija Island on Comoros, their big island, which had an MDA campaign at the end of 2013, along with a mass distribution of LLINs. And they had a remarkable decline in transmission, from 55,000 cases in 2013 to around 22,000 cases in 2014. Now, during this period from 2014 to 2017, there was still a significant amount of population-level immunity on the island. And it's during this period that finding that the afebrile parasite reservoir is likely to have been very important. And in fact, because that was not addressed very effectively, they are now starting to see a resurgence in transmission. If they had been, I think they didn't think that they were going to be as successful as they were, and they weren't ready to go in with a very intensive surveillance system afterwards. And in some ways, I think we lost a great opportunity to potentially eliminate on Ngazija. But I think currently the threat is not of the afebrile infection reservoir. The threat is populations that can't access health services, either because they are mobile populations that don't have easy access or may not even have legal access in a country, rather than asymptomatic infections. So just to summarize, WHO supports all countries in their malaria elimination targets. But we do know that in Africa in particular, malaria elimination has to start with the high-burden countries, and the high-burden, high-impact initiative is a great first step to trying to bring down those areas that have the highest level of transmission and are going to be the last areas to eliminate in the world before we get to eradication. The malaria community needs to start considering how do we engage men in malaria prevention and elimination. It's a new population to us. It's exciting to think of starting to work with a new population, and we need to start that now. Border areas need to be analyzed, and cross-border transmission foci need to be treated as such. We need to start thinking programmatically, how can we do that better? And the long tail of elimination means most populations have little immunity at the end. But this might change, and in fact, we hope it will change. We hope that we will start to find ways to eliminate transmission more quickly, and under which circumstances then afebrile cases may become more important. Thank you very much.
Thank you very much, Kim. That was excellent first talk. So we do have time for just a few questions. Can I follow up with what Bill said? If you're going to ask a question, please say your name, where you come from, and use the microphone, as this has been screened for other people outside Johns Hopkins. So questions for Kim.
This is always the bad part of being the first speaker. Nobody's quite warmed up yet.
Yeah, there's one up there.
I'm Clive Schiff from Johns Hopkins. Kim, I had the pleasure of working on malaria control in the days when WHO did actually put people in the field to do work. And this was an important contributor to the success in my country, which is now called Zimbabwe. I haven't, WHO now doesn't, so my take is that WHO is actually a key player in this whole process. My concern is that there are not sufficient funds available to WHO to take a much more aggressive role with expertise, because the value of WHO is that you put experts into the field to train local people. And that's how success occurs. So is it possible that we could put some pressure on donor countries to support WHO further?
Thank you. I totally agree that having been outside of WHO most of my career and working at the country level, I know how important WHO is to country staff. It is a member state organization, which means all of the countries are members of WHO. There's no external interests involved. And that is very important to being able, for countries to be able to feel that they can trust the advice that's being given. Not that other people can't be trusted, but they know that WHO is their organization. I don't know how to respond on the finances issues. It's something that I find shocking that WHO is not better funded. I could say that in our global malaria program department, maybe 4 or 5 people have sort of core funding and everyone else is on soft money. This is not the way that WHO should be working. But in a very small way, we are starting a pilot program called Stop Malaria. We're piloting it in September this year, which attempts to address that to a small degree. This is based off of the very successful Stop Polio collaboration between CDC and WHO, where people can volunteer for a 1-year unpaid internship, but you're well compensated in terms of living allowance, to work with countries in elimination settings in the last areas to be eliminated to try and provide that surge capacity that countries may lack, especially when malaria is no longer a public health problem, to help them finish the transmission off in that area. If this proves to be successful and if we gain further funding, we also hope to expand this into the high burden areas so that people could be stationed in subnational areas to help with the high burden countries. This is also a way to establish a global malaria workforce. I think it's a great opportunity for students to go out and get a year's worth of very solid programmatic fieldwork under their belt for whatever comes next. They have a great understanding of country context while they're working to support national programs. So thank you very much for that comment, and totally agree.
One more question.
Thank you. If it's okay, I have just a couple of questions, if it's okay. My first question, first of all, Scott Lefebvre, I work with Catholic Relief Services. We're a major partner of Global Fund, primarily in control countries, in high burden countries. I guess just 2 quick questions. One is, given the fact that, as you mentioned, the high burden, the high impact, approximately 70% of malaria burden is in those 11 countries. And I understand the role of WHO in working with all countries, but can you speak to, say, the level of effort by WHO as compared to where the burden is? I mean, sometimes it seems like a very democratic thing where everyone's screaming, we want to eliminate, et cetera, and then you feel like dispersed. But if 70% of the burdens in 11 countries, how can you focus attention there? And it's a very real problem. I mean, we face the same thing where we have partners who are saying, please help us, but we're working in places like Nigeria and DRC, which hold, over 1/3 of the burden, in those 2 countries. The second question, I guess, is just on the male issue. Has anyone tried MDA with just that population?
Yeah, okay. It's a difficult question. WHO is focusing more on those 10 high burden countries now than they were, say, 2 years ago. But we also do face then criticism because there are many other countries that may not have the highest number of cases but have intense transmission. So it's a bit of a balance. But it's not just WHO. The countries themselves are standing up and taking leadership in this effort. And then there are a number of partners, and most prominently PMI, that work in all of these countries as well. So it's a bit more about realigning, reorienting, collaborating better, and not so much that WHO has to shift its focus. And then there are examples in the greater Mekong of not so much MDA in perhaps more like prophylaxis in men, but not MDA per se, as far as I know.
Okay. Thank you.